And I think since we are recording, we could proceed.
Okay, great. Thank you, Kelly. Good afternoon, everyone. I'm Steve Shell. I will call to order the Treatment and Recovery Subcommittee meeting. It's great to see everyone today. Before we move forward, we need to establish quorum, so we will do roll call. Kelly, I apologize. I don't have the list of our members in front of me. Can I call upon you to go through our membership? And oh, there we go. Sorry, Kelly. Thank you. You think of everything, Kelly. Thank you.
Yeah.
So starting with the roll call, Assemblywoman Claire Thomas.
Here.
Chelsea Cheatham. Dr. Leslie Dixon.
Here.
Jeffrey Iverson.
Here, and good morning or good afternoon.
Good afternoon. And Dorothy Edwards.
I'm here.
Wonderful. So we definitely have quorum and we can proceed. So thank you. Next item on our agenda is public comment. I'll just read a brief statement and then turn it over to Kelly to share more details. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. So Kelly, I'll turn it over to you to share some additional details.
Thank you, Mr. Chair. So if you're dialing in from a telephone in the United States, please dial 1-253-205-0468. And then when prompted, the webinar ID is 8948937528. And if you would like to make public comment, please press *6 and we will unmute you. If you are on the Zoom call, you can also raise your hand or unmute and request to be acknowledged by the chair. So, Mr. Chair, I do not see any hands raised for public comment.
Okay, thank you, Kelly. That concludes public comment. We'll move on to item number 3 on our agenda, which is a review and approval of our minutes from our June 4th, 2024 subcommittee meeting. Hopefully all of our members have had a chance to review the minutes.
You're talking to Laura.
Okay. Hopefully our members have been able to review the minutes, and if so, we will entertain a motion to approve.
Jeff Iverson, I'll make a motion to approve.
Great. Thank you, Jeff. Do we have a second?
I'll second it, Dr. Dixon.
Thank you, Dr. Dixon. Is there any discussion regarding the minutes? Okay, all those in favor, please say aye.
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 Any opposed? Motion carries unanimously. Moving on to item number 4 on our agenda, we're very excited to have Assemblyman David Orentlicker with us here today. The Assemblyman is a professor of law at UNLV's School of Law, as well as the director of the UNLV Health Law Program. And he is also a physician, so has a very interesting background. So we're very excited to have him with us today to talk about harm reduction. So Assemblyman Orentlicker, we will turn it over to you, and thank you so much for being here today.
Well, thank you for inviting me. I really appreciate your interest. So I got interested in this area back about, well, 6 years ago. At the law school, we do an annual program on an important health policy and law issue. And the topic in February of 2018 was the opioid epidemic and how we can address it. And one of our speakers was from Columbia School of Public Health, the Professor Joanne Chetta, and she talked about the experience overseas with overdose prevention sites. And it was really exciting to hear about how effective they've been in addressing some of the problems. If you look at the countries that have them, they dramatically reduce overdose deaths from opioids. They reduce transmission of HIV, hepatitis, and other communicable diseases. And they connect users to treatment for substance use. There's also, they help out with instructing users on wound care and connecting them with other needed health care. So in terms of, the model of harm reduction, ideally, nobody would be using controlled substances unless with a prescription, but that's not the reality. And whatever we can do to reduce the harm as we're trying to get users to treatment so they can stop using. And so as a result of that conference, that led me, when I became a member of the Assembly, to introduce legislation to see if we could authorize pilot programs, maybe one in Clark, one in Washoe, on a pilot basis, to see if we could replicate the success in other countries with overdose prevention sites here. And the idea of the overdose prevention sites is, it's like you've heard the presentations, but just somebody tuning in who isn't familiar, the idea is that people who are using drugs, they have a substance use disorder, and being able to do it in a supervised setting. So if they do overdose, they can be quickly revived. They can we can make sure they use sterile needles and syringes. And importantly, we can connect them with treatment and other support services. They might need housing, employment. So give them opportunities to connect them to treatment for their substance use and other social services, and hopefully start the process so they can stop using the drugs. So I've introduced bills, I said, in 2 sessions, and we're still in the proposal stage. But one of the things I've learned when I've talked to people who are involved in the harm reduction sphere here, including Chelsea, who's on your group, and Lisa Lee, and Rick Reich at Track the Exchange, is that this is a progressive process in terms of when we look at you. I know you've heard from Kalen C, and when they opened their overdose prevention sites, they did it in facilities that were well established in providing harm reduction services, kind that are legal here and that we're already providing: the needle and syringe exchange, the wound care, the connecting to treatment, and having facilities that were well established in their communities, had built trust with the potential clients and also the residents of their neighborhoods. And so I'd like to, so that's something I've been working on with Rick, to see if we can do more of that capacity building and increase our infrastructure in harm reduction, to lay the foundation. So when we get to the point where we can introduce overdose prevention, we've already have well-established harm reduction facilities in the parts of the city where it would make sense. Right now, at his brick and mortar facility, he also has vending machines throughout the state, but his brick and mortar facility is on Charleston, I think, by Jones, and it would really be valuable to have a site, a harm reduction facility on the east side and on the Maryland or Eastern Avenue corridor around, Sahara Desert Inn. And it looks like he's found a place that an empty building that could be used, and that's one of his projects right now. So my ask for you all is, I think the more you can do to help build the harm reduction capacity so that we have sufficient facilities in the areas where we need them to start building up to overdose prevention, and get them, again, with the trust of the people who would use it, the buy-in from the community, and there's plenty they can do already under current law with harm reduction, and get all of that well established, and so that we're ready when the time is right to take the next step into overdose prevention. be happy to take any questions.
Do we have any questions from our committee members?
Mr. Chair, I see Assemblywoman Thomas raised her hand.
Oh, thank you, Kelly. I couldn't see. Yes, Assemblywoman Thomas, I'll turn it over to you.
Thank you so much, Chair. And thank you, Assemblyman Ornlicker, for coming to speak with us. That last statement that you made, because I'm concerned, because on the east side of town, we have lots of schools, not only CCSD, we have charter schools, because we're trying to get our children in educated in underserved communities. But when you said buy-in from the community, how do we go about those PSAs that won't frighten the community with harm reduction facilities coming in?
Yeah, no, that's a very important question. And so one of the things that's been challenging for Rick as he's looked for a site is we don't want to, nor could we do it across the street from a school or by a child care center. And there are quite a few in the areas that make sense. So he's been looking, and the site he's found is in more of a commercial area, commercial intersection, so that it wouldn't be right by a school. But interestingly, in New York City, I know that one of the facilities there is across the street, either from a school or a preschool, but something along those lines. So that was encouraging to hear that they have been able to work with the community, even with a school, although we're not interested in doing it across the street from a school. But that if they were successful in getting buy-in in that setting, that makes me confident that we would be able to do that. But this is something we would want to have discussions with the local community and make sure that they're comfortable opening it, and that we're and obviously, and a very important thing is for the site to make sure that, you know, there's not drug use in their parking lot or around the corner, that people, one of the important services they provide is to collect used needles and syringes, and to make sure that people are dropping them off and not leaving them outside. So one of the good things with the experience in New York City and Canada is we can get a lot of good guidance from them on how they were able to establish good relationships with the community.
Any other questions from our subcommittee members?
Yeah,
Dr. Dixon, yes.
I can't find the hand raising thing on the computer, but anyway, yeah. So I used to live in New York City. It's very, very different from Nevada, from Las Vegas, Clark County, et cetera. It's so compact and we're so spread out. So, so some of the issues that, and I'm a practical person, one is that how many, I mean, you want one pilot program, which is good. Obviously you start with one, but I don't know that you're going to reach a lot of people in any one program because it's so spread out. Another problem we have is public transportation is terrible. I have patients that come to me that take sometimes 2 to 3 hours just to get the bus to where I am, and then I know they have to take it back. But the big issue that I see is funding. How in the world are you going to fund something, or are you proposing to fund something like this? Because these are professional staffing that you have to have there. I mean, it's just. So you not only do you have rent and all the costs of a building or a space, you've got to pay all the professionals. There's a liability issue, so somebody's going to have to carry some decent malpractice, and And maybe that's what you're here hoping that some of this opioid money, but that money is kind of temporary, doesn't last for very long.
Yeah.
How would you propose to fund all this?
Yeah, that's a good question, and I can partially answer, and I would encourage you to invite Rick because he knows this much better than I and where the funding streams are. But has a long track record working with CDC and other potential funders, and I've gotten the impression from him that he can find grants to get this up and running, and also to sustain it. But obviously, having some of our opioid dollars will be very helpful. But as I say, it'd be one of the obstacles we have right now is it'd be great if he had somebody who worked full time for him writing grants, which he doesn't. So that slows things down. But
There have been some grants come out of this from the Resilient Nevada Fund. They put out requests regularly for funding. Has anyone applied for any of that money?
Yeah, I don't know, but that's a good question.
And then my other question is, relates to the patients themselves. These folks use, they don't use once a day. They use many times a day. Because both fentanyl and heroin are very short acting. And so they spend much of their time looking for their supply frequently and touching base with their dealer, etc. But would you propose that a place like this would be open 24/7 or just work hours?
Yeah, so that's an important question too. You're right. Some people do frequent use, and ideally it would be 24/7. I don't know if that's how feasible that is. And so you're right. For some users, you might be able to meet their need for the entire day with being open 8 or 12 hours, but others, yeah, it may not be sufficient. So you're right. Ideally we would have several facilities because, as you say, we're not as people are all over the city. We don't have public transportation. They'd all be 24/7, but I think getting started and seeing, how we can build on it. I know that one model is to you have your central facilities, your brick and mortar, but then you can send, staff out to meet users where they are. And so that's something that might be worth looking at for Las Vegas at some point.
One other thing would be about the people who they don't just use opioids, they use a lot of meth, and they can be very unruly, let's say, when they're under the influence of meth. So you have to think about you're going to have good security, in other words, and have a way to get these people where they need to go.
Yeah, and that was one of the things. Kaylin C. did come out and meet with us. It's been a year or two. And one of the things that she mentioned was, how you design your program turns a lot on which drugs are being used, how are they injection drugs? Are they, smoking? What is their path of administration, which drugs? And that would be very important for us to look at what model is going to work for Las Vegas, because each city is going to have different patterns of use and a different model for these sites.
That's all for me. How did you all find the hand raise thing? I can't find it.
Did you have another question, Dr. Dixon?
No, I'm done, so I don't need it, I guess.
Okay, thank you. I do see we have Dorothy Edwards and Assemblywoman Thomas with their hands raised. Dorothy and then Assemblywoman Thomas.
Please let me yield my question first to the Assemblywoman.
Thank you, Dorothy. I'll turn it over to Assemblywoman Thomas.
And see, if you'd have called on me, I would have yielded to Dorothy. Okay. Okay. Thank you, Chair. And thank you again, Assemblyman Orenlicker. I just wanted to just go through some of the good points that that we just heard from Dr. Dixon. And I'm hoping that you can get back to us with how the use of the funding stream, the possible funding stream, after you speak with, I think you said Rick.
Rick Wright, yes.
And also, I wrote down the hours, expected hours of operation, just to clarify what the models would look like, you know, conceptually, what the models would look like here in the South and in the North. Also, I was looking at security. Would that security be 24 hours? Because whether or not you're open for 8 hours, you would still need security for that building regardless, you know, 24. And then the biggest hurdle, I think, is transportation, as Dr. Dixon, whether or not this location would be in an area where, you know, like if it's Maryland Parkway, that's really where the RTC concentrates. So, you know, if it's in a strip mall, what transportation would look like in that area. And I think those are the only things that I would ask you to get back to us so that we could actually, you know, formalize her concerns, because I thought they were really great. And Dr. Dixon, you see where it said has the heart and it says react, that's where you'll find the hand.
I don't think it was there. Now I see it, but anyway, it's appeared. Thank you.
Thank you.
Okay.
And thank you, Chair.
Thank you,
Thank you.
Assemblywoman Thomas. Oh, go ahead, Assemblyman.
Yeah, thank you, though. I'll definitely follow up on those questions and get you the answers.
Next, I know Dorothy Edwards has a question.
Good, well, it is. Good afternoon, Dorothy Edwards. I actually just had some clarifying questions, and I think I got the answer to one the Assemblywoman asked. You kept referring to Rick, and I must have missed. I wasn't sure who, but I got that, Rick, right. And then did I understand that you're planning on introducing legislation this coming session, or not?
Yeah,
Again?
so I haven't decided yet.
Okay.
As I said, I think, you know, focusing on building the capacity
Mm-hmm.
is priority right now. And
Okay.
sometimes a legislative proposal can be distracting and counterproductive. So that's, you know, over the next few months, I'll
To be
get a
determined.
sense of whether this is a good time or whether it's better to, as I say, build the capacity and then in 2 years do the bill. You know,
Thank you.
interestingly, yeah. So I'll leave it.
Great. And I see Dr. Dixon with her hand raised. Dr. Dixon.
So it's kind of plays off of what she just asked is what the community, how are you going to get the community on board on this? And part of it, I guess, is the legislation, which has been a pushback for so far. Do you think things have changed, that people are more in favor of this? And then, of course, with the present administration, I don't think things are probably have changed all that much.
Yeah.
So,
Yeah,
so
I mean,
anyway,
yeah.
I guess that's the thing is, what are you doing to make this popular with the community?
Yeah, so once we find a site, then we can start to work with people who live there. And sometimes you find with these kinds of projects that the opposition is really from people who don't even live in the community, who this is an issue that they're advocates regarding. And I think our hope is that we'll be able to work with the people who live in the neighborhood and assure them, because one of the things we can all point out to them is right now they're suffering from, the presence. When you have drug use in your community, there are a lot of collateral consequences, and having a facility can help reduce the discarding of needles and syringes in public places. It will reduce the use of bathrooms and public libraries by drug users. So this is something that has been successful in improving, the environment in the communities where they live with regard to drug use. And I think showing them that, I think will help a lot with getting them comfortable and supporting the idea.
Assemblyman, I had just a couple of questions. I first wanted to ask, who is Rick Wright associated with? What is the name of his organization?
Track B Exchange.
Okay, good to, so he is with Track B. Good to know. Thank you. And then the other question I had, Assemblyman, is I just wanted to get you to elaborate more on what your recommendation is to us. Is your recommendation to build harm reduction capacity through the funding of pilot harm reduction facilities?
Well, I mean, we don't need to pilot the harm reduction facilities. This has all been approved and they're in existence. It's just that we don't have enough. Our capacity, given the size of Las Vegas and the amount of drug use, to have one brick and mortar facility, that's just inadequate. So building the capacity now, and then when the time is right to do a pilot program, we'll have a place to do it, rather than have to say, okay, we don't want to do a pop-up pilot program. We want to have just as in New York, place that's well established, and again, the community is comfortable with it, and the people who would use it are already tied in. Because even if we opened it tomorrow, are the users going to trust it, right? Because how do they know? Their initial fear is, the police will just be sitting across the street watching who goes in and out. And so we need to make sure that they get to know the service providers and the facility, and see that it's a place that respects them, and that they'll be treated safe, that they'll be safe. And once you've got that, then you can then talk about adding overdose prevention. Yeah.
Great. Thank you for that clarification. Assemblyman, I know you referenced Lisa Lee earlier during your presentation. I know she's on today from the public. I believe Lisa may have a question. So if so, I'll turn it over to Ms. Lee.
Oh, hi. Well, thank you, Chair Steve. Gosh, I didn't know I could ask a question. So good to see you, Dr. Orentlicker. This has come up in Northern Nevada Harm Reduction Alliance quite recently, and we've been just learning all we can about different state laws that, as you know, OPS has come on board. Rhode Island, Boston just passed some regulations around this as well. So we're kind of watching. There's also like a national overdose prevention center work group call run through DPA, Drug Policy Alliance. But my question is, we've seen here locally a big shift from injecting to smoking. And given the current regulations around like smoking equipment is still considered paraphernalia in NRS 453 Chapter C. And so I think that's one element, a legislative element that's going to have to be finagled as we see a shift towards smoking, which is also a harm reduction technique, right? Like, we're happy that people are not injecting and that they're smoking, yet we have these legislative and regulatory barriers to be able to really connect with people who are smoking and who are not sort of, going to harm reduction services. They're not getting those supplies up here legally. And there's been a bust recently in Carson City. So I'm just kind of wondering, like, what other work needs to be done to prepare for uptake of something like OPS in the legislature. I think that the safe smoking definitely needs to be addressed. Also, like, when Change Point started here, there were conversations with the police departments and MOUs with the police departments that they would stay away and not surveil the syringe services program. And, Change Point opened, we were all there a decade ago when they opened in 2014. So there's all these pieces of community building that need to happen. And I'm just wondering, is there a plan? Is there an appetite for legislative change around decriminalizing or smoking supplies, similar to what we did with Senate Bill 410 back in 2013 with hypodermic devices? Or what does that look like, I guess, is my question around smoking.
Yeah, so good question. So when we decriminalize testing, fentanyl and other testing strips, we did discuss, so back 3 years ago, we did talk about a broader decriminalizing. There wasn't the appetite then. So I was very pleased to see when Attorney General Ford presented at Interim Health with the recommendations of your full committee about decriminalizing drug paraphernalia. And I think, and I want to do things is to follow up with him and ask him, tell him, I'm willing to sponsor that bill, and is this something that, how can we make this happen? So I definitely, you're right, that would be an important part of our laying the foundation. I've also met with the sheriff in Clark County, started discussions about this, and he's willing to work with us on this kind of a project. So obviously a lot will depend on the details, but he understands the need, and that we need more services in this area. So a lot of things, parallel tracks we'll have to be working on over the next year or two.
Great. Thank you, Ms. Lee, and thank you, Assemblyman. Any other questions or comments? Assemblyman, we really appreciate you taking the time to be here today and share information with us on such an important topic. So we all look forward to continuing to work with you. We will definitely follow up with Rick. Great. And ask him to bring some additional information to our subcommittee. But again, we really appreciate your time today. So thank you for being here.
Sure. Thank you for inviting me. Look forward to continuing the discussion.
Thank you. Moving on in our agenda, item number 5 is up next. This is a discussion of the NRS requirements for peer background checks that resulted from a previous discussion we had in our last subcommittee meeting. So I will turn it over to Laura Hale. Hello, Laura.
Oh, sorry. Now I got it. My thing disappeared when the screen changed over. But thank you, Mr. Chair. Laura Hale for the record. So there was a recommendation regarding the background checks that are conducted by the Bureau for Healthcare Quality and Compliance in relation to peer recovery support specialists. And Kelly, if you could share the document or go to the next screen, whichever is easier.
Oh, sorry.
That's okay. So the response that we got, we did reach out to the chief of the Bureau of Healthcare Quality and Compliance, and he sent to us a couple of references. So this one under NRS 449.123, that's where this all comes from, indicating that the administrator or the person licensed to operate a facility, hospital, agency, program, or healthcare home shall obtain a written statement from the employee of the temporary employment service or an independent contractor stating whether he or she has been convicted of any crime listed in NRS 449-174. And Kelly, if you go to the next screen, that should show the specific detail there. So you may recall from the discussion last time around, there were issues about use of substance. So obviously with peer support specialists, they're likely to have that kind of background, but this is actually in the statute. So when the Bureau of Healthcare Quality and Compliance, as part of their duties, are overseeing the hiring of those folks, they have to go back to this statutory requirement. So there's both the background with item A sub 8 there that references possession, distribution, or use of controlled substances or dangerous drugs. And then there's also item C, if there's a substantiated report of child abuse or neglect made against the person, or and if the facility or home provides residential services to children, that can come up as a red flag. So if the subcommittee members want to go forward with trying to change that, there would have to be a bill draft request. And I don't know if on the next slide, if you have more of the regulation, Kelly. So this LCB file number R093-22 is what the Bureau did put in place, but this is just the method by which they do their work that is required of them to follow that NRS that we looked at above. So basically the Division of Public and Behavioral Health, they use existing law, which prohibits person who has within the immediately preceding 5 years had a substantiated report of child abuse or neglect or certain certain related violations from serving as an employee or independent contractor who provides or supervises the provision of peer recovery support services in a position where the person has regular and substantial contact with minors. So, you know, the regulation always comes under the statutes as a way for state agencies to do the work that the statutes require them to do. So I hope that is clear, but if you have questions, I can try to answer them. This is basically what was provided to us by Paul Schubert, who is the chief for that bureau that does this oversight. And that's it, Kelly.
Laura, thank you so much. That was very helpful. You actually brought to my attention, I've been saying that it was 5 years for the drug offenses, and I'm glad to know that it actually says 7. Well, I'm not glad, but I'm glad you clarified that it does say 7 and not the 5.
Yeah. So it's 5 years for one thing and 7 years for another thing. But hopefully that's clear to everybody now.
Yeah, again, very helpful, Laura. Do any of our subcommittee members have any questions or comments? Okay, if not, we'll move. Thank you again, Laura. We appreciate your help.
You're welcome. Thank you, Mr. Chair.
Moving on to item number 6 in our agenda is an overview of recommendations received and our next steps. Before we open it up for discussion, I wanted to ask if there is a recommendation from our subcommittee to bring forward a recommendation from Assemblyman Orrin Licker's harm reduction presentation. So at this point, is anyone thinking that there is a possible recommendation from his presentation, or are we thinking more information may be needed, as was proposed about Rick Wright with Track B? I'll just start. My thought is that I think we need more information from Mr. Wright, in order to proceed with deciding if we want a recommendation in this area. I know he raised several things that he said Rick could clarify for us. So that would be my recommendation to all of us at this moment, is that we invite Rick Wright to bring us additional information to support Assemblyman Orrin Licker's presentation. But do any of my fellow subcommittee members have any comments around that?
I would agree, more information.
Thank you, Jeff.
Sorry, Jeff, for the record.
Thank you, Jeff.
It is Dr. Dixon. I would agree, more information, but I don't think the timing is good. And if you talk with people in the PAC coalition, they're not very much in favor of this at all. And I think there needs to be more information, not just from Mr. Wright, but from the communities that have tried this. There was a big article in the paper yesterday about a New York program. I can't remember if it was in the Sun or the RJ, but whatever. And but I think the practicalities that I and the others were bringing up are really major. These are major problems to solve, and the not in my backyard tends to be very strong in this community, and I'm sure it's true in the rest of the state. They had a terrible time just getting the state psych hospital built, and so I don't know. I like the idea of getting people into treatment and saving them from their actions, but I don't know. I have a hard time with this one ever going anywhere anytime soon. Anyway.
Thank you, Dr. Dixon. Anyone else from our subcommittee?
Yes, Assemblywoman Claire Thomas, for the record. Dr. Dixon brings a very, very good analysis of what we think the community. I was just wondering, and I know that this is not a debate stage in this treatment and recovery subcommittee, but I would actually like to hear from those that oppose, because we're hearing people that are for, and I think to get a better idea of what could come about, I think that sometimes we need to hear the opposing side of this also. But that's just my opinion. But thank you.
Thank you, Assemblywoman Thomas. I would agree with you on that as well. I think that we need to hear both sides, really, to make a more informed decision on how we would want to proceed with a recommendation, if any. Any other comments from our subcommittee?
Chair, this is Dorothy.
Yes, Dorothy.
I agree. I mean, I think, we need to present an equitable decision. I guess and forgive me if it was something that occurred before I came on board this year, but I'd like a little data. I like, we hear, oh, it works great here, but I like numbers. I'm kind of numbers, and Nevada's unique. It's, not New York. And I don't know. I think when we ask for more information, maybe just some data to back where we're going. So I'm just kind of a numbers geek, but thank you.
Thank you, Dorothy. No, that's an excellent point, Dorothy. I think data would be very helpful for this discussion. Any other questions or comments from our subcommittee? Okay, regarding Laura Hale's presentation, I wanted to ask if there is any recommendation at this point for hospital background checks on peers. I know she mentioned that it would take a bill draft request. And Kelly, I'm not sure if we can use that as part of our recommendation to the SURG. Maybe I could turn it over to you just to help us elaborate on that.
Thank you, Mr. Chair. So Kelly Marshall for the record. So we do have your original recommendation related to HCQC. So when we review that under this agenda item, you could suggest or propose a different recommendation. There is certainly nothing that precludes requesting legislation. I don't know that the recommendations have requested a BDR or bill draft request as much as they have like recommended that legislation be brought forward to ... And so that's one option, right? That you could take the existing recommendation that you had and revise it and shop it with this subcommittee.
Okay, that's very good, Kelly. Thank you. Any other comments regarding that before we move on to the review of the other recommendations at hand?
Well, I think this, Dr. Dixon,
Yes,
I
Dr.
think
Dixon.
that Kelly's right. I think probably it is something we should discuss in the complete search committee, because I mean, obviously we would want our chair, Mr. Ford, on board with us, or at least to give us some insight into what he thinks about going this direction. I mean, I can see the reason we would want it very much, because I'm sure that a lot of the people that would be good peer support counselors have been in trouble with the law because of their drug use in the past. And so we would like them to be more available. But I think he probably has much better finger on the pulse than the rest of us do of whether this has any possibility of going anywhere. The other person, of course, would be Assemblyman Yeager, who's the chair, and he has been one of the people that have put through some legislation and changing sentencing guidelines and stuff like that for people. And so he might be somebody who might be interested in carrying something like that.
Yeah, very, very good point, Dr. Dixon. I think we would certainly want to defer to our chair, Attorney General Ford, and get his insight, like you said. Okay, so I know next up as part of this
Mr.
agenda
Chair,
item,
can I
we
just
wanted
check
to.
to see?
Yes, Kelly.
If Jeffrey Iverson wanted to make a comment, he's on.
Oh, I'm sorry.
So I wasn't
Sorry
sure.
about that, Jeff.
No, I'm fine.
Okay.
Okay.
And then,
Thank you.
Mr. Chair, just one other point, Kelly Marshall for the record. So we are going to review after this agenda item, the process for bringing recommendations to the SURG, to Dr. Dixon's point. And so I think there will be more clarity about that. And there's certainly every recommendation that comes out of this subcommittee then has to be vetted by the full SURG. So there should be an opportunity for that to happen in our October SURG meeting.
We're not meeting until October?
The full SURG would be in October.
That's a long ways off. There's a lot that can happen between now and then. Yeah.
And we have one more, just on that note, Dr. Dixon, we have one more subcommittee meeting prior to that full SURG meeting. So we still have time in September to decide what we want to move forward to the full SURG in October.
What's the date?
Kelly, yes, Dr. Dixon.
In September?
September 3rd is our next subcommittee meeting. All right, thank you, Kelly, for clarifying all of that. So I know we next wanted to move on to Dorothy Edwards' bill and walk through that again.
Well, Dorothy Edwards for the record. So first, wasn't mine. Michael Berry, presented this, BDR idea to the Washoe Regional Behavioral Health Policy Board, of which I, facilitate, and our chair is also chair of that board. And, as you may or may not know, the policy boards, there are 5 in our state now. They are gifted with a BDR, which is certainly something we value. And so I solicited everyone far and wide, for people to come forward with BDR ideas around behavioral health. And Mr. Berry presented this one. Our policy board voted on what to move forward with their BDR, and we did not choose this one. We actually selected a parity bill, and so probably hear more about that as we move forward. But out of respect and the idea, I did tell him I would bring this forward. I do understand, and I would need to probably get more clarification before we went too far on whether to support it or not. When we had a guest in speaking with our LCB analysts, it was my understanding that this might have been picked up or merged with another potential BDR, so it may be being heard and encompassed, and so that would be great, because I think it's Mr. Berry was passionate. We did at our policy board. I think it's important to note that we had quite a bit of public comment and support, both verbally and via emails for this. So it was something people feel strongly about. But I think it might be being run by someone else. And again, I apologize. I don't have more information on that. I can certainly try and get some for you for our next meeting, since we are meeting in September. Our policy board had to, we have to get our our BDR out by September 1st. So that's why we voted on that. So I don't know if that's helpful or not, Steve, but I just wanted to share that and make a disclaimer that it may be being picked up in some form. They never quite look the same, but
Thank you, Dorothy. And I know, Kelly, I think we want to go through each of the recommendations, and then we can then decide as our subcommittee how we want to proceed from that point.
Yes.
Any questions for Dorothy about her recommendation? Any other questions or comments from our subcommittee members? Okay,
Mr.
thank you,
Chair,
Dorothy.
just one point
yes,
of
Kelly.
clarification. So Kelly Marshall for the record. So if a piece of legislation is being proposed and this subcommittee supports that legislation, there have been recommendations developed to support that EDR, so that the SURG goes on record, which this report with the recommendations that you all bring forward will be published in January, right prior to the legislative session. So I think one does not preclude the other.
right. Do you, for the record, Dorothy Edwards, to you, Kelly, so we view that as a letter of support. Is that an official letter of support like our boards would give, or just a recommendation to the big surge, and the big surge then does a letter of support based on our committee?
In essence, Kelly Marshall for the record, in essence, the recommendation serves as evidence of support by the whole surge if it's included as a recommendation. And that typically does get presented in January to a number of policymakers.
Perfect, thank you.
Great. So moving on to our second recommendation that we've been considering. This was from Chelsea Cheatham, our fellow subcommittee member. I know Chelsea's not with us today. But just in reading her recommendation number 2, to support access and linkage for treatment of trauma for people with substance use disorder or those who have overdosed, and for surviving family members after an overdose fatality, and to support training for healthcare professionals to identify and address trauma. So do any of our subcommittee members have any questions or comments regarding this recommendation from Chelsea? Anything else to consider regarding this one?
Mr. Chair, I would just note that at a previous SURG treatment and recovery subcommittee, this subcommittee expressed a positive view on this recommendation. And so I think at this point, it's moving forward in the queue to be voted on based on the process that this group will decide on today or recommend today for inclusion in October.
Okay, great. Thank you, Kelly. Okay, moving on to the next one. This was one that I had submitted to our subcommittee. And you'll note from the recommendation that I actually made, had misspoken about the 5-year requirement for the felony conviction regarding drug offenses. And I'm so glad that Laura Hale clarified today that it says within 7 years. So I would certainly want to change to the recommendation to reflect that change. But also back to Kelly's point, in terms of the fact that we can't necessarily propose a bill draft request, but we certainly could propose to the SURG that legislation be considered. I would want to rewrite my recommendation, Kelly. So is that just simply a motion that I need to make?
You could, so Kelly Marshall for the record, and I see that Rosalie Bordelev has joined us from the Attorney General's office. So Rosalie, I don't know if you want to weigh in on, and no action has yet been taken on this recommendation. The subcommittee is still considering it. So if Steve wanted to revise this recommendation that they've heard previously, but not taken action on, what would you advise?
I mean, to have any official change made to the recommendation, there'd have to be an action, but you're saying just revise what's in the materials because there hasn't been an action yet. Yeah, that can be changed. That can be part of the action that is taken to approve this, can be with changes. So it's just whatever you guys approve in your motion is what will become the recommendation.
Yeah. So Rosalie, if I'm understanding correctly, then that would mean that Chair Shell could revise a recommendation, present it in September to the subcommittee for them to then take action on.
Yes.
So Steve, if you were not quite ready to have it wordsmith today, that would be the next step.
Okay, yeah, and that would be the move that I would make, Kelly, is I would wordsmith this prior to our September meeting and then bring it forward to the group at that time. So thank you. I see that Assemblywoman Thomas has her hand raised.
Okay, Assemblywoman Claire Thomas for the record. Thank you, Chair. Now that you will bring it back to us on September 3rd, I believe, because my question was, what in here did you see that you wanted to change or revise?
Great question, Assemblywoman Thomas. Thank you. I wanted to change in the third line where it says 5 years. I wanted to change that to 7 years, just to reflect what the current statute states. But I also wanted to add that I would be recommending that legislation be considered to change those guidelines that HCQC is currently following.
All right, thank you so much.
Yeah. So I'll wordsmith that and then bring that back to all of you in September for consideration. So thank you. The next recommendation we had was from a previous presentation from Dr. Kelly Morgan regarding the Bridge program. And we haven't had anyone that has formally come forward to make a recommendation regarding the bridge program. So we wanted to ask our subcommittee today if anyone is volunteering to build out a recommendation on this, or are we agreeing not to move this forward? Any comments from my fellow subcommittee members? Kelly, it doesn't look like anyone is volunteering to move this forward. So I see Assemblywoman Thomas with her hand raised.
Okay, Assemblywoman Claire Thomas, for the record, one thing they taught me in the military is never volunteer. So I'm not volunteering, but I am, I think Dr. Morgan's bridge program should be carried forward. And I'm hoping that someone would mind doing it.
If none of my fellow subcommittee members are volunteering to move this forward, I will take that on and bring that back to our committee meeting in September. I'll be glad to take that one on. Thank you, Assemblywoman Thomas. Okay, so next, you may remember in a previous meeting, we had a presentation from Dr. Lee Sedera on alternative treatments regarding acupuncture. And so this is another one where we don't have a formal recommendation to be considered by our subcommittee to move forward to the SURG. So we're asking if anyone would like to volunteer to bring this forward to work on a recommendation, or are we saying that we're not necessarily going to move this topic forward? So any questions or comments from our subcommittee members? So based on that, I'm not getting that we have any interest in anyone formalizing this as a recommendation to move forward. So at this point, Kelly, are we just basically saying we're tabling this topic for now? Okay.
So Kelly Marshall, for the record, I don't think we're taking any action one way or the other because I don't hear any motion. It doesn't mean that it's dead. Certainly any subcommittee member could determine at any point, and I'll make sure and send out the link to how to submit a recommendation again to the subcommittee after this meeting. Subcommittee members are encouraged to submit any recommendations as they emerge, just based on their own practice. And I would just say that we do need to finalize recommendations in September. So the window for doing so is starting to close, just so that we could bring recommendations forward to the full SURG in October. So if subcommittee members have a desire to bring forward a recommendation, please look for the email from me with the link and you can submit it. And then we will review them all at the September meeting. And it can be related to this recommendation, any previous presentation, or just something that has emerged in your own practice where you want to bring forward a recommendation.
No, thank you for that clarification, Kelly. Dr. Dixon, I see you have your hand raised.
Well, yes, I have a lot of problems with this recommendation. It's the fact that it keeps that 3 of the 5 bullet points talk about working with U.S. Congress and Senate. I mean, I always have problems with recommendations that are going to be difficult or impossible to implement. And I don't see this as very implementably, or however you want to say that. We have enough trouble working with our own legislature, and I don't know that we have any real who in the world would do this? So that's, I guess that's my problem, is I see it's great ideas and would love to see the US Congress and Senate do all kinds of stuff, but I'm not sure we need to be making recommendations like that. So.
Thank you, Dr. Dixon. I see Dorothy Edwards with her hand raised.
And just really dittoing and supporting Dr. Dixon and on the fourth bullet, only because as we're talking about our parity issues, you know, insurance should acknowledge, well, again, it's easy to say what they should do, but it's quite another challenge, you know, working with these hardworking folks, you know, but so it just seems kind of broad and impossible. Not casting aspersions on acupuncture, but it just we want to be a subcommittee that brings forward strong, clear recommendations that don't look a little cloudy or nebulous. At least that's what I would want. So I just kind of smiled when I was reading what insurance should do. But just saying. Thanks.
Thank you, Dorothy. Okay, so as Kelly had said earlier, you know, time is of the essence. So at our September subcommittee meeting, that is going to be the time when we have to refine our recommendations and take action on what we want to move forward to the full SURG meeting in October. So just something for all of us to keep in mind. I know we have some follow-up items after today to bring to our next meeting in September. And then at that time, as Kelly said earlier, we can then determine, you know, what action to take, if any, on those recommendations to bring to the SURG committee. Does anybody have any other ideas for any presentations that you may want to see at the September meeting regarding any other possible recommendations that could be made?
And Mr. Chair, Kelly Marshall for the record, I just wanted to request, is the direction of the subcommittee for me to try and secure Rick Wright for the September meeting, or is that a recommendation related to harm reduction that the subcommittee thinks will not be part of September and you would have a chance to workshop after September?
Is anyone opposed to bringing Mr. Wright to our September meeting? Is everyone feeling like we need to vet this a little bit more regarding harm reduction?
Yeah, I think we should have him if he's available.
Okay.
I agree. There's no harm in having him and listening to what his thoughts are and what his plan would be.
Great. Thank you. And then I wanted to say to Dorothy's point earlier, if there was any way to get some data that we could also review during that meeting. And I'm not sure, you know, Rick may certainly have data, Kelly, that he could bring to our group.
And Assemblywoman Claire Thomas, if we can also during that time get opposition too.
Yeah, excellent point, Assemblywoman Thomas. Does anyone have any thoughts around the opposition on who we could possibly invite? Maybe we think through that a little bit more, Kelly, and
yeah, I would say this is Dr. Dixon, that we might ask, well, Chelsea maybe, and then because she works with Dr. Jamie Ross on the PAC Coalition, I think that might be, they might have a good person to talk. So I would probably say to reach out to Chelsea and Jamie. Jamie's on the, she on the Acorn? I think she's on the Acorn.
Mr. Chair, I can certainly do that.
okay, thank you, Kelly. That all sounds good. Does anyone have any other suggestions for presenters for our September meeting? Okay, hearing none. You'll notice this slide is showing our next subcommittee meeting dates. And as we've been saying, September 3rd is going to be a very critical meeting. for us all to decide on what action to take regarding the recommendations to bring forward to the full SURG committee meeting in October. And then at that time, we will then receive direction from the full SURG committee on which of our recommendations may need to be further considered at our November 5th subcommittee meeting. Is that correct, Kelly?
Yes.
Okay, thank you. So we still have a lot of work to do this fall, but definitely a lot of work to do in our September 3rd meeting so that we can then make a decision as a group on what we want to take forward to the SURG committee meeting in October. Okay, moving on to item number 7 on our agenda. This is the approach to recommendations, the recommendations ranking process. And Kelly, I may, if you don't mind, I probably will turn this over to you just to walk us through this. I know for those of us that have been on the SURG and the subcommittee for quite a while, I know we've been through several different ranking processes. And so it would be helpful to kind of enlighten everyone on this.
Thank you. So Kelly Marshall for the record. So the SURG has not been in existence for very long, and the process for developing recommendations has been evaluated each year and then revised based on feedback from the full SURG and then also the subcommittees. So we're trying to just refine the process so that it works best for you. And so we wanted to note like what has been done in the past. So in the first year, every subcommittee developed their recommendations. They presented them to the full SURG. We had weighted recommendations. When multiple members ranked it as their top recommendation, that recommendation had a higher score. The full SURG then evaluated that and basically adopted a slate of recommendations. When we did the ranking process in 2023, you may recall, again, subcommittees presented their top recommendations. There was a preliminary ranking, and so the SURG ranked that full slate of preliminary recommendations in October, and then some of those recommendations were refined. Your chair just alluded to that in the placeholder meeting in November, which is when a recommendation comes back from the SURG and they say, can you add this piece, or can you think about combining it with this other subcommittee's recommendation, or could you strengthen this part so that we can fully support it or change the language? And so those final recommendations then came back in December, and they reflected not just the ranking, but we actually listed them in relative importance. So they were ranked 1 through 18. And there were some recommendations that the subcommittee or that the full SURG determined they would not rank or weight, but they wanted included as an unranked recommendation. So that happened in 2023. A third option that has been proposed by at least one subcommittee chair is to have the entire SURG rank recommendations by subcommittee topic area, so that there would be, here are the treatment and recovery recommendations, and they would be ranked within them, and then harm or response and prevention, and potentially harm reduction as a fourth. It's not a subcommittee, it's just attached to other subcommittees. So I think given the approaches used in the past, and there's a likelihood that there will be fewer recommendations, the question and the request for feedback to this subcommittee for discussion would be, how would you suggest the subcommittee move forward with recommendations? Do you want to retain the process that was used last year, where there was preliminary ranking and then final ranking of all recommendations not listed by subcommittee, but just based on the merit of the recommendation? Or would you like them to be done by subcommittee topic area? And are you still in support of having ranking in order of importance? So I think this is really what we're trying to take a temperature reading from the subcommittee members about what they feel would be most meaningful going into the final report and how we depict the relative importance of various recommendations across the three subcommittees, and then the fourth topic of harm reduction.
Kelly, I'll defer to my fellow members before I share my thoughts. Does anyone have any comments? I just wanted to share for myself, Kelly, that I like the new option. I didn't realize that would be a possible option. The reason I like that option is because I think it would heighten the awareness of each of those subcommittee topic areas. I kind of felt like that sort of got lost in our previous rankings discussions. And I think this new option would elevate that importance of each of those topic areas. That's just my opinion.
Is there, Dorothy Edwards for the record, is there, again, and I wasn't part of the last session's discussions, but is there a concern about the quantity or the number of recommendations? I mean, in my mind, it's quality over quantity. I'd rather put forward 3 very strong, researched, well fleshed out recommendations than 6 or 7, or am I misunderstanding? Because I see a couple statements, you know, fewer recommendations and being encouraged to bring forth recommendations. So is there a quantity over issue here?
Mr. Chair, would you like me to respond to that?
Would you, Kelly? Thank you.
Sure. So Kelly Marshall for the record. Ms. Edwards, thank you for that question. What I can tell you historically is that in the first year, so the 2022 recommendations, there were a lot of recommendations. I think they were up to or close to 20 or 22.
Wow.
And so there is some argument about dilution of support with so many recommendations. In 23, there were, I believe, 18. I'm going to ask Laura Hale to check my work here. 18 ranked recommendations and then 2 additional unranked recommendations. Laura, am I close on that?
Yes, you got it, Kelly.
Okay. And so again, that same thought, that is that too many? I think we had initially asked subcommittees to try and limit their recommendations to 5. So more in like the 15 range, but we were also dealing with harm reduction, which does not have a subcommittee, but kind of crosses over in different subcommittees. As you heard Assemblyman Orrin Licker today, you know, he was talking about harm reduction, but there's a direct linkage to treatment and access to treatment. So there's some flexibility there. And so I think there certainly isn't anyone who has expressed opposition to the idea that less is more, particularly if they're quality versus quantity, and wanting to have some traction and attention to the recommendations that the subcommittee and the SURG works on throughout the year. So I don't know if that's a response that answers your question, but it provides some context.
It absolutely does. I appreciate the history.
This is Jeff Iverson for the record. Am I free to speak?
Absolutely, Jeff. Yes, thank you.
So I like the new option, but I also like limiting the number of recommendations. I feel like it gets a bit overwhelming when, you know, we have so many. And I think if we were able to reduce the number and really like put forward recommendations that we feel A will be taken seriously and B can be implemented. So, but I think that the entire, I liked was it a doodle poll or like, I can't remember the term for it, but less is more. I have to agree with Kelly on that.
Thank you, Jeff. I agree with your point. I kind of felt like last year there were we had so many to consider that I was worried at the time I was overlooking something of importance. And so I do like the fact, that I do like the idea of trying to limit and maybe keep it within those topic areas. Dr. Dixon or Assemblywoman Thomas, do either of you have any thoughts?
No, I think I guess the middle one, the 2023 method is what I would probably go with. But I agree with keeping the numbers down, and make them, whatever it is, make the recommendations practical so that they could be implemented. So, which brings me to a related question. Are we doing any kind of follow-up on the previous to see what's happened with them? Do we do that?
Mr. Chair, I
Kelly.
can field that. Yes, Kelly Marshall for the record. Thank you for that question, Dr. Dixon. So the Division of Public and Behavioral Health is slated to provide updates on the previous year's recommendations. They've already provided some updates to us for the 2022 recommendations, and I think we're asking them to currently work through the 2023 recommendations. I believe that will be on the agenda for the October SURG meeting, so that you will have some sense of progress made. And I do know that at a previous SURG meeting, there was also a presentation on the status thus far. So periodically, there are updates that the state provides to us of what has happened in terms of progress with the recommendations.
Good.
So Kelly, at this point, you're basically just taking our feedback back to the Attorney General and his staff.
So the idea is that we would take the feedback back and provide it to the Attorney General, and the Attorney General will make a final decision. So
Okay.
I've heard preferences. I don't know if the subcommittee wants to come to consensus on what one voice would sound like. I mean, what I heard thus far was a desire to have thoughtful, meaningful, quality recommendations with some agreement of doing them by subcommittee as opposed to the full SURG, and that no one is opposed to limiting the number of recommendations to make sure that they all have sufficient error once they're published.
Well, in order to obtain a consensus, I would make a motion to reflect what Kelly just stated.
I'll second that. I do agree.
Thank you, Jeff. Is there any discussion regarding this motion on the table? All those in favor, please say aye.
Aye.
Any opposed?
Aye.
Any opposed? Motion carries unanimously. Okay, that concludes item number 7 on our agenda. Moving on to public comment. Again, I will read a very brief statement. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241010. And Kelly, I'll turn it over to you to share any other additional details.
Yeah, so if you would like to make public comment, please go ahead and raise your hand. If you are joined by Zoom, or if you're dialing in from a phone in the United States, please dial 1-253-205-0468. And when prompted, you can enter the webinar ID, which is 8948937528. If you press *6 on your phone, the host can prompt you to unmute. Now that we've opened public comment. So, Mr. Chair, I don't hear anyone requesting or see any hands raised for public comment, and I don't see anybody who has unmuted themselves.
Okay. Thank you, Kelly. That concludes public comment. Before we move on to item number 9, which is our adjournment, do any of our subcommittee members have anything else to mention today? If not, we will look forward to seeing everyone on September 3rd at our next subcommittee meeting, and we will adjourn this meeting and end on time today. Thank you all. Have a great day.
Thank you.
You
Bye-bye.
too. Thank you.
Thank you.
Bye now.